Welcome, I'm so glad you all could join me. I'm Chava and you're watching Ask a Midwife.
Hi everyone, this is Chava Ben-Sion and you're watching Ask a Midwife. I'm so glad you could join me today. Let's talk a little bit about inductions. This is a pretty big subject and I get a lot of calls and letters about inductions. A lot of women today are being encouraged by their doctors to have an induction. What is an induction? An induction is basically a process where the pregnant woman will be given there's a few different kinds of medicine, basically a chemical, to induce or start contractions which would lead to labor. And there's a few different ways for doing that. Now, before I talk about the ways that an induction is performed, let's talk a little bit about why an induction would be performed. A normal pregnancy length is 40 weeks. That's 40 weeks from the woman having the first day of her last menstrual period until the due date. It's a guess. Most first-time moms, for instance, often carry their babies for about a week longer than the average woman who not having her first baby. So, for instance, if a woman is having her first baby and she's 40 weeks plus 5 days, that's really normal. She's not really even technically overdue. Although a lot of times a doctor would give her reasons why we need to induce, like your water level, your amniotic fluid is low, you have a higher risk of having a stillbirth. There's a lot of reasons, and they're not usually founded in sound medical science, unfortunately. We find that when a woman's labor is induced, her chances of the baby's chances of having fetal distress, which is basically where the baby tells us through his heartbeat that he's not feeling well, that he doesn't like what's happening. That's the risks of fetal distress go up when a woman is induced, as well as the risks of having a cesarean section, a surgery to bring out the baby. So there are reasons why a woman's labor would ideally need to be induced, but a lot of the reasons that doctors are giving women nowadays are actually not really founded in the woman's own personal situation, but more in a liability, a way to cover their own liability. So listen, there are women out there who need an induction. I personally experienced an induction with one of my own pregnancies, and it was necessary, and I feel very confident that it was necessary, and I feel good about it, and I feel like it was an appropriate choice for me. But there are thousands and thousands of women, and I'm very concerned that they're being railroaded into an induction that they don't really understand what an induction of labor consists of, what the risks are, and why they're even being scheduled for one. And a lot of times a woman will feel quite powerless in the face of her doctor. She ascribes a lot of knowledge to her doctor, and her doctor has skills and experience and knowledge that she does not possess, and at the same time he's taking care, or she's taking care of the baby, the woman's baby, and there's there can be a lot of fear involved. So unfortunately, let's divide up two reasons, the two categories of induction. Let's divide up medical necessary induction versus elective induction. Okay, a medical induction would be like the woman has a monitor, which means they monitor the baby's heart rate, and it's seen through the fact that maybe the baby looks a little bit stressed. We have something called decelerations of the heart rate, and basically the baby tells us how he or she is feeling through the heart rate and the movements. Okay, so let me just repeat that again. The way we know the baby's okay in there is from the movements, so the fetal movements, the kicks. When we say kick counts, that's what we mean. The fetal movements and the heart rate. The heart rate should have variability. It should go up and down, but not dip below 120 and not exceed 160. So an average fetal heartbeat is always beating between 120 beats to 160 beats per minute. It's a lot faster than our adult heart rates. And if the baby is moving and active in there, the heart rate should go up. And if the baby is sleeping, the heart rate should be lower and probably less reactive, with less variability. And if the baby moves in there, we should see reactivity, which means it goes up. And in general, we should see that it goes up and down throughout the monitoring span. Okay. So generally, if we monitor a baby and we see that there's not a lot of reactivity, which means the baby's, maybe she's moving in there, but the heart rate isn't going up, that's a concern. If we see the heart rate going down, especially during a contraction, but it could also just go down in response to the baby's movements, maybe there's pressure on the cord, and we're not really sure about what's going on, but we see evidence through the baby's heart rate that there's a problem. We might change the woman's position, we might check again. This is, sometimes this happens when the woman's being monitored in early labor. Sometimes she's not in labor at all, and that's in the case of an induction. An induction means we're starting labor there's no labor and we're starting labor. That's what an induction means. Augmentation is when there's already labor, there's already a process, she's already contracting, and we want to step things up a bit. So that's called augmentation, and that's not what we're talking about right now. We're talking about induction. Okay, so there's evidence that there's a problem with the baby. Also, maybe there's a woman who has gestational diabetes, and they're concerned about the baby's physical status. There are women in with a situation of having gestational diabetes who have the doctor saying, well, we need to induce, because statistically, if you have gestational diabetes, they want you to induce sometimes by 39 weeks, sometimes by 40 weeks. They say that the rate of stillbirth goes up. There's rates of heart problems. There's rates of breathing problems that go up with becoming full term. However, if the baby looks great on the monitor and the baby's not too big, even in a case of gestational diabetes, a lot of times they'll just suggest to be induced anyway. Now that can be, most of the time everything turns out fine and the woman didn't really need to be induced, but that's one of the cases where we really have to take it on a case-by-case basis. But sometimes it can be a medical necessity, and a lot of women who have gestational diabetes, especially if it's not controlled well with diet, they are at higher risk, so that might be a need for a medical induction. There are lots of reasons why a woman would need a medical induction, and usually she'll know why. A non-medical induction is more like, well, the baby's getting a little bit big, and we're not really sure if your pelvis is big enough, so let's just induce now while you're still, 39 weeks, 40 weeks, and let's not let the baby get too big so you can't give birth to your baby. Now that's not really, there's no way to say whether or not the woman can birth her baby. The pelvis changes, the baby's head changes throughout the process of labor coming down into the pelvis. There really isn't a way to say, unless she's, a 4.5 foot tall woman with a, 15-pound fetus in there. Generally, the pelvis can move and flex, and the baby's head molds to the shape of the pelvis, and sometimes bigger babies are a little bit more difficult to give birth to, but recovering from a C-section and experiencing a C-section is pretty hard on the body, so I wouldn't say it's definitely a medical necessity just because the baby's big. A lot of midwives can attest to the fact that big babies are born, and a lot of times they're born more easily than smaller babies. It just depends. The real issue with the size of the baby is less about the size, and it's more about the position of the baby. And I'm not talking about a head down baby versus a breech baby. I'm talking about there are 360 ways to be head down, and there are a lot of different angles that the baby could have his or her head cocked to this way, extended a little bit, which it increases the diameter of the head. Things like having the arm up by the neck. There are a lot of things that can make the baby seem like a larger baby, but in fact it's not really the size, it's the position. And so a larger baby in a good position, a head down position with the chin tucked to the chest, is actually usually fine. Even a 12-pound baby can come out pretty easily if it's in the right position. So a medical necessity would not necessarily be a large baby. Also, low amniotic fluid. I really have to talk about this one. A lot of times a woman says, wow, I just got back from my appointment and the doctor said I have low amniotic fluid and they have to induce. And I'm thinking, I don't usually say it because I'm more professional, but I think that is the most ridiculous idea I have ever heard. The reason that there's a concern about the amniotic fluid is because that one of the main jobs of the amniotic fluid is to protect the umbilical cord, which is basically floating in there with the baby. But the umbilical cord brings oxygenated blood and nutrients to the baby and removes the waste products and the deoxygenated blood away from the baby. And so it's a lifeline. Of course, it needs to be free to flow. Now, if there's no water, the water acts as a cushion. So the water protects that umbilical cord from pressure. Okay, now if the water is low, it could be for many reasons. Maybe the woman hasn't been drinking. Maybe it's been hot out and she's a little bit dehydrated. Maybe she hasn't been eating well enough. There are a lot of reasons, and also from day to day, the water level can fluctuate. A normal water level is between 5 and 25 on a scale called an AFI. It's called Amniotic Fluid Index. And basically, 5 is the low margin of normal and 25 is the high margin of normal. A lot of times a woman with a 7, 5, 6, 7 level, even though it's low, it's borderline, it's not considered subpar in terms of, it's still okay. And at full term, it's also very common for the pockets of amniotic fluid not to equal more than 7 or 8. So a low amniotic fluid, unless you're seeing distress on the baby, is not really a reason to induce. It's actually a reason to go home and eat a big meal and drink a lot of water throughout that next day, 24 hours to 48 hours, and check again. As long as the movement counts are good and there's no distress noted on the fetal monitor, it's a really ridiculous reason to induce, just because of low fluid. Now, if there are other factors, obviously the midwife or doctor is going to think of those and consider those, but just having low fluid, my suggestion to you ladies who have had, a doctor tell you, or someone tell you, wow, you have really low fluid, my suggestion is to ask, okay, what's the number? As soon as they say this is low, or this is not an acceptable level of anything, or the measurements are off, your next question should be, okay, what are the numbers? And where do I fall in relationship to the normal? Because a lot of times we'll just get flooded, we'll get emotional, think, oh no, the water's low, there's going to be a problem with the baby. And we don't always stop and think, well, okay, wait a minute, how low is it? So we have to still keep our heads about us, keep our wits about us, and become advocates for ourselves and our babies to avoid unnecessary procedures, which do significantly raise our risks of more unnecessary procedures. So, unfortunately there are doctors, and I'm talking to you in internet land, so I'm assuming that there are going to be women in Nigeria and in Oklahoma and in Kathmandu and all the different places in between. So, and I do know that worldwide a lot of women watch this channel, and I'm really glad. So I'm saying I understand that you're all going to be facing a different situation with regard to your maternity care. Hopefully you have a maternity care provider, maybe you don't. But anyway, there are different reasons. Like some physicians would actually say, well, I'm not going to be, they might say to themselves, like, I'm taking a vacation next week, so let's go ahead and induce you, so I'll be here. That's not a medical reason for an induction. Okay, and unfortunately, as much as it would seem convenient, wow, I really want my doctor, I love my doctor so much, I really want him to be here, it's not a medical reason, and it will significantly raise your risks. I'm so sick of carrying around this pregnancy. I'm so uncomfortable. I'm just done. I just want to get it out already. That's not a reason for an induction. In fact, some of the most important things in the whole gestational process of the baby being ready to be born happen in the last, few weeks and days. Like your baby's storing up the rest of his or her nutrients, her iron stores, her lungs are becoming, they're finishing the maturation. She's gaining the weight that she needs to gain. She's all her, neurologically, there's so many functions that happen in that last little phase. And also, on another level here, I'd like to just draw your attention to the message that you're giving your baby with a non-medical induction. It's basically like, we've waited for you all this time. We've waited to, if it's a planned pregnancy, we've waited for you. We've waited to become pregnant. Now we're pregnant. If either way, if it's not, you've waited your whole pregnancy, and it's not comfortable to be pregnant, but you've waited. And then in the very, very end, rather than giving your baby the message of, we love you so much that we're going to give you the time that you need to get ready to come and be a part of this world with us. It's like, no, you're going to come on our terms. You're going to come on our time because we're tired and because we don't want to do this any longer. Look, it's very legitimate to feel that way. But the message that you're giving your child who only has one birth experience, and, the message that they're getting, which is like, there really isn't any reason we're going to pull you out of there before you're ready to come, before you give us the signal. That might not be a message that you want to give your baby. But I'm not trying to guilt people who need to do that, because we also as midwives, we understand that like it's not just about the baby, it's about the mother, because the mother and the baby are a unit. So the mother has to be okay in order for the baby to be okay. So if the mother is truly suffering, I'm talking about a deeper degree of suffering, a more profound degree of suffering than, well, I really just want to get this over with. This is really hard for me, or I'm scared of labor. I don't like the idea of waiting. Waiting is really hard. Is it going to happen here? Is it going to happen there? It's hard to plan. It's hard to schedule. Those are normal and natural feelings that most all women go through in the end of the pregnancy, and that's not a reason to induce the baby. But I'm talking about a more profound level of mental, emotional, and maybe physical well-being that needs to be addressed in terms of the end of the pregnancy. So I'm not, this isn't like a black and white kind of, rule here. It's just, we have to take the mother into consideration, but if she can hang in there a few more days, another week, and do the things that are, good for her well-being, to nourish her, to hydrate her, to rest her, to sort of wrap up her pregnancy experience in a positive way with support. The woman who feels that way doesn't necessarily need an induction. She needs support. She needs someone to come in and clean her house. She needs a friend to come and take her out to lunch. She needs her husband to, maybe say, let's watch a movie together. Whatever. I'm saying she needs some kind of support. It doesn't necessarily mean she needs to run and get hooked up to Pitocin. So I'm going to actually speak about the process of induction in my next video. So go ahead and click on the next part of this video to see how an induction is performed.